Thank you very much. In which case, may we move straight on to the next formal item on the agenda, which is the Chief Executive's report.
Thank you, Malcolm. So, first up, I think we should all place on record our thanks to the staff of the National Health Service and indeed our own staff, particularly in the Commissioning Operations Directorate, for the enormous work that went in over the Christmas and New Year period. As Richard will report, actually, although the NHS was very busy, generally we had a less pressurised Christmas and New Year than last year, and there were some fundamental reasons for that. Flu rates were lower, the flu jab worked better, there were more beds available, the weather was milder, but that should not obscure the fact that also there was much stronger operational preparedness on the part of the vast majority of hospitals and very strong joint working between NHS England and NHS Improvement. So we are taking a clear look at the things that generated that improvement that were within our control over the course of the last month, 6 weeks, and are looking to ensure that those lessons are learnt for next winter. One thing that I think we will need to see further improvement on is the rates of flu vaccination, both for at-risk groups in the population and also for NHS staff. In effect, the effective flu vaccination rate was higher this year, if you think of that as the number of people times the effectiveness of the jab, but the fact is that we have got more opportunity there for next year. And I also, as I note in my report, I think we shared in the joy at seeing the NHS choir reach the number 1 slot over the holiday period, displacing the true believers.
Terrible.
Thank you.
Terrible.
Just to prove that spell check can be overridden on formal reports. More importantly, now, of course, we are getting into the hard business of closing out the 15-16 and ensuring that the funding and contracting arrangements for 16-17 are in hand. Paul will talk about the 15-16 financial position, not just for NHS England, but for the NHS overall. In terms of 16-17, at our last board meeting on December 17th, we made the allocations of funding to CCGs. We have subsequently been doing a lot of work on the incentive programs, the so-called Sequin for next year, the standard contract, and the tariff consultation, which we think will be relatively uncontroversial. With Monitor, we will be issuing that very shortly. And we also have the job to, again with NHS Improvement, jointly agree the performance trajectory that individual hospitals will need to deliver during the course of next year if they're to get access to their share of the 1.8 billion that this board allocated for sustainability funding for next year. We've issued the blessedly concise planning guidance to the National Health Service since we met last time, and have attempted to be very clear about the core things that we need to secure in 16-17, but also the quite significant gear change we want to see in terms of the type of conversations and the planning processes which are used to think through how the health service puts itself on a trajectory to improve health, redesign care, and deal with financial sustainability, the triple challenge we set out in the forward view between now and 2020. And we're envisaging 2 kind of milestone points, check-in points, April and June, July, and we'll be setting out more detail on that again within the next week or 10 days. Between now and our next board meeting, or looking forward certainly into February and early March, I do just want to draw attention to 4 things that are of significance in terms of major upcoming reviews that are likely to be published. We are highly cognizant of the pressures on general practice, and that case has been heard. I think the National Audit Office produced a report looking at funding for general practice, making the point that, relatively speaking, it has fallen behind other parts of the health service over a decade or more. Also showing that since the creation of NHS England, rather than seeing real-term cuts each year, actually for the last 2 years, general practice has seen increases. So the pivot has begun, but there's a lot more to be done. At the December 17th meeting in allocations, we put our thumb on the scale to ensure that general practice would see funding increases of at least 4% a year over the next 5 years. But of course, that is the floor rate. That does not take account of additional resources that CCGs will be able to invest in primary care through CCG co-commissioning. It does not take account of the share of the overall sustainability and transformation fund that we'd expect to see invested in expanded primary care services over the next 5 years. It does not take account of the share of technology or primary mental health care funding and other funding streams that we want to see. So we're working closely with the Royal College of GPs and the General Practitioners Committee on what a comprehensive package of support for general practice should look like. Obviously, just a small building block of that is ensuring that the 16-17 GP contract is reasonable to all sides, but nobody is of the view that by itself that represents the sort of support that GPs will clearly need. On mental health, we, under the leadership of the Independent Mental Health Task Force, they have set out their stall on some of the key improvements that they want to see, which we have backed, but their comprehensive report will be published within the next several weeks, and that contains a number of really important themes, one of which being that if we're serious about parity of esteem or equal treatment for mental health problems alongside physical health problems, then for all the talk of 7-day services and crisis care on the physical health side, that same level of access should be available at times of mental health crisis. They also make the point that for many people with mental health problems, their physical health needs are going unaddressed. For many people with long-term physical health problems, their mental health needs are going unaddressed. So a big focus of the expansion in psychological therapies will be in that area. And thirdly, they make the point that unmet mental health needs have big impacts on life chances and on broader well-being, including the economic and inequality prospects of many people across our country. And so viewing the investments we need to make in mental health services through the life chances, inequalities and economic benefits lens is particularly important in this area. Thirdly, the work that Julia Cumberledge and Cyril Chantler have been leading on maternity services, particularly looking at the lessons of the Morecambe Bay inquiry, given that Dr. Bill Kirkup and Catherine Calderwood are on the review panel. That work is nearing its conclusion, and they expect to be able to publish that by the end of February. And then fourthly, the work, not our strategy, but a strategy to which we're contributing, the government's childhood obesity strategy. We have continued to take a leadership role in terms of the contribution that the NHS can make there, including in respect of reducing the obesogenic environment, thinking about regulatory or fiscal measures that could be taken to get junk food out of the NHS, and better support for patients and for staff and for visitors. The two final things I wanted to say were, one, in respect of the junior doctors dispute, and to just remind the board that under the Civil Contingencies Act and the Health and Social Care Act, at times of industrial action or other service disruption, NHS England has statutory responsibilities to oversee the preparedness and the response of the NHS as a whole. And so I want to thank Bruce and Anne Rainsbury for the work that they did during January in respect of the strike that took place then. As things stand, there is further action planned on February 10th, and it's fair to say that most hospital chief execs and the relevant people across NHS England are concerned about the effect that further multiple days of cancelled operations or outpatients would have, or indeed the withdrawal of emergency cover. We have welcomed the fact that Sir David Dalton, Chief Executive of Salford Hospitals, on behalf of the NHS, has been assigned the role of lead negotiator, and endorsed the view that Frankly, if David is unable to get a workable negotiated agreement that works for both sides with the BMA, then it's not obvious that anybody else can. So it is very important that both sides use the opportunity presented by David's engagement to come to a workable solution. If that doesn't happen, it's not clear that any alternative approach would generate that. And then finally, I just want to add our congratulations, Malcolm, to our own staff and our partners who were recognised in the New Year's Honours. Keith Willett, Director of Emergency Care, Geraldine Strathdy, our Clinical Director for Mental Health, Stephen Groves, our Director of Emergency Preparedness, who's led a lot of the work on Ebola last year, as well as, of course, Harpal Kumar and Paul Farmer for their leadership roles in respect of our work on cancer and mental health.
Thank you, Simon. Just on that point, to record for the board that I have, of course, written formally on behalf of the board to our own staff to congratulate them on that. Let me invite questions and comments, please, on Simon's report. In which case, I shall take it as being received by the board. And thank you very much, Simon.